Now I request Dr. Anita to her presentation on finding clue in optic nerve for unexplained visual loss.
Good afternoon, everyone. I'd like to thank AIOC and Dr. Nagendra sir for including me in this IC. I'll be talking on finding clue in optic nerve for unexplained vision loss. So sometimes ophthalmology makes us feel no less than Sherlock Holmes. So whenever we have a patient with unexplained vision loss, we start from the beginning. We look at the lens, we look at the cornea, the retina, the vitreous, and then finally we look at the disc. Everything else is fine. We look at the disc. Something is really not right, and then that raises a red flag. So there's certain clues which an optic nerve can offer, and that is in the form of a disc edema, pallor, or a afferent pupillary defect. But these clues sometimes are very subtle. So there are two things. One, that we miss these clues. Secondly, we see these clues of disc edema, pallor, and we don't know what to do with it. We don't know why it's there. So in neurophthal, the best thing is to start from the very beginning when you are having any doubt, and the history will only give you a lot of clues, as Dr. Nagendra sir has said. You have to find out about the onset, whether it's a rapid onset, whether it's a gradual onset, associated neurological symptoms of jaw claudication, any weakness, any phenomena, like the patient might say that I take bath and my visual symptoms worsen. This might point to a multiple sclerosis. So history taking is very important in a case where you're suspecting optic nerve to be the culprit. History of ATT, linezolid. You have to know what is the latest fever on the block. Is it dengue? Is it chikungunya? Is it COVID? Because all this has bearing on any optic nerve disease, addictions, medical history, hypertension, diabetes. You can have NAION, hereditary optic neuropathies. Find out if only the males are getting, maybe you're having a LHON. So after we're done with the history, we just review again, we check the visual acuity again, see the pupil reaction, color vision, the color desaturation. These are all very simple optic nerve functions. And if we have an afferent pupillary defect, dyschromatopsia, then and a field defect, you're probably dealing with the optic nerve lesion. These are certain ancillary tests which we use, VEP, OCT, RNFL, the ganglion cell count, the fields, the imaging, and Eureka, you have the diagnosis. One of the most important things is missing the RAPD. That is something we miss. We immediately dilate and we're just set to look at the cataract and the retina. So one thing is whenever we have this unexplained vision loss, we should just have a look at the RAPD again. So RAPD, there should be ideal light, the fixation target. Another thing is the reverse RAPD. For example, if you have a traumatic optic neuropathy with the efferent defect, you don't know why the vision is lost. Iris atrophy is the pupil is not reacting, but why the vision is gone. So do you reverse RAPD? Instead of doing the swinging light and seeing from the worse eye from the better eye, put it on the worse eye, check the better eye. So you do a reverse RAPD and you just might get an traumatic optic neuropathy in the eye which you thought just had an efferent defect. So if you do all this properly, you will not be able to miss out a subtle RAPD. Now, retrobulbar neuritis, disc is okay. Posterior ischemic optic neuropathy, disc is fine. Again, the RAPD is going to help us. The color vision, the color desaturation, fields, and of course imaging. But small tests can also help us in finding out the diagnosis. And once we realize, of course, we know that we can find out the causes of the RBN or the posterior ischemic optic neuropathy. Perioperative vision loss, posterior ischemic optic neuropathy should be foremost in our minds. Disc edema. So this is one of the clues which the disc can give us, the optic nerve can give us, that of disc edema. We know the differentials. Sometimes it's not so obvious. We miss the disc edema. If you just look at the disc under the lens, only the nasal part is blurred. Sometimes it's only the superior pole, the inferior pole where the edema is hiding the vessel. So it might be a very subtle disc edema which you are missing. If you look at figure 1A, that is a picture of a Leber's hereditary optic neuropathy with a circumpapillary telangiectasia. It's not very obvious, at least not to me. After a month time, this disc becomes pale, So this is something which we're missing, and we should see that area also. The figure 2A is of a non-arthritic ischemic optic neuropathy. Here the disc edema is quite obvious, but sometimes it's not that obvious. In that case, have a look at the patterns line, which are concentric retinal folds temporal to the disc. When the disc becomes edematous, these folds come up. These are the patterns line. They will give us a hint that probably there is some disc edema. Then check the other eye. Check the disc of the other eye. Maybe it's a disc at risk. There's a small CD ratio, and so that corroborates your diagnosis that is it an NAION that I'm dealing with. And these are certain things to look for when we are looking at a disc edema, whether it's a hyperemic disc, look at the margins and nerve fiber swelling, patterns line, tortuous vessels, all this. Then again, as I said, history, what's happening in the medicine OPD is important. Now, this patient had a sector disc edema, not very obvious. But something was looking wrong, so we went and did the fields, and we got an altitudinal field effect. There was history of COVID. After COVID, because of the hypercoagulable state, there can be a NaON. This is again a post-COVID vaccine, optic neuritis both eye. Very subtle disc edema, but the vision was less. The angiogram corroborated the diagnosis of optic neuritis, and there was history of vaccine, the AstraZeneca vaccine. This is another patient who came to us with a vision loss in both the eyes. The left eye, okay, if you see this, just mild nasal blurring of the blood of the disc margin, and the other eye looked normal to us. We did an OCT. So sometimes, the OCT also helps us a lot. It corroborates, the disc is looking suspicious and you see the RNFL thickening. So we can see that the RNFL was thick in two quadrants. But surprisingly, the left eye showed a temporal pallor. In the RNFL, there was RNFL thinning. And when we took history, there was history of 3 weeks back, the patient had only 1 day of fever. And because dengue was prevalent at that time, we got a dengue test done. It was positive, and the patient was diagnosed with dengue optic neuropathy. And this has bearing on how we treat these patients, because infective optic neuropathy has to be treated with antibiotics, and we have to control the inflammation also. So I think I'll just go fast. And again, this is a patient with, again, disc edema in one eye. The other disc looked okay, but the GCC showed that there was some problem with the ganglion cell count. Took history. They don't want to give history of spurious alcohol consumption, but here it was given, and then the diagnosis changes. We know the cause of the disc edema, and we treat accordingly, which is very different from how we treat other cases of optic neuropathy. Okay, this is very interesting case. This was a 56-year-old person recently came to us insisting he had a vision loss. The disc was okay, vision was 624, he had some cataract. Finally, I just got fed up and got a field, and there was a right inferior quadrantenopia. And this is the MRI report. There was old infarct with glautic changes in the left occipitotemporoparietal cortex. So the patient might be having a field defect, and his vision is look okay, but basically he's not able to see in a particular field, and he thinks that his vision has gone down. So basically, his complaint was of loss of vision in a particular field. So visual fields, when you have doubts in the optic nerve, do a field, do the color vision. Visual levered potential is also very important. In this patient with a posterior ischemic optic neuropathy, the disc was fine, but it was the P100, the latency of the P100 which was increased, and which told us that there was a problem in the optic nerve. So these are how not to miss the disc edema. Get a stereoscopic picture, look for patterns lines, look for spontaneous venous pulsation. If it's present, there's no disc edema. And of course, take help of OCT and visual field. Another hint that the optic nerve gives us, another clue that the optic nerve gives us is that it becomes pale. And this is a list of reasons why it becomes pale. So pale disc, we again go back, there'll be reduced visual acuity, contrast. If it's a bilateral disc pallor or something, then you might not get RAPD, but otherwise you're going to get RAPD. Subtle optic atrophy will be difficult to see. You have a look at the surface capillary net. Then the surface capillary net will be thin. Look at the early finding, and look at the red free lights. There'll be loss of peripapillary retinal striations, which looks like rake defects. Partial optic atrophy, temporal pallor, band atrophy might be difficult to see. Total optic atrophy, difficult to miss. This is a bow tie atrophy, which is seen in a optic right. This is a right optic tract or occipital lobe lesion, where you can see. Just have a look. There's a bow tie type of a pallor which is seen. This is very easily missed. Again, this is a patient with a nutritional optic neuropathy, temporal pallor. Okay, it could be more subtle than that, and then it's a field which comes to the rescue, and you have a central or a centrocecal scotoma, temporal pallor as a result of nutritional optic neuropathy. The right eye, this is normal NFL, and the other eye shows early changes, early optic atrophic changes of rake defects following focal damage in the red free light. You can see that arrow. Or you can get, this is from the net, ischemic optic neuropathy, you can see wedge defect. So you can get these defects which points towards a optic nerve damage. And in the other eye, we don't see any of that, and that's a optic atrophy case. Sometimes in drugs, for example, anti-epileptic drug like vigabatrin, even in ethambutol, I have seen there's concentric vision field loss, and the pallor comes much later. As somebody has said, disc pallor or the lack of the pallor is an enigma. And you can see this patient who was an anti-epileptic has a concentric field of vision loss, but the disc was not pale. This is another girl, who came to us. She was sent to us from the neurology department. They had seen disc edema. They had given her IVMP. They didn't know why the vision was not improving. And we did the OCT RNFL. It was not that bad except for a slight temporal thinning. But when we did the GCC, just look at the inner retinal layer thinning, the IPL and the GCC. It's all in the red. So we thought, okay, maybe this is a neurodegenerative disorder. There was this article which I saw which said about Alzheimer's disease and said that the GCC gets thin. So this was a sign of a neurodegenerative disorder. We got a conduction, an NCV, nerve conduction test, and it came abnormal. Subsequently, she was diagnosed with a demyelinating disorder and treated accordingly. This is again a pregnant lady who came to us, dikh nahi raha hai, right? But the vision was 6'9", 6'12". So as we ordered a field. Field is such a handy thing to order. We ordered field, we got a bitemporal hemianopia, and she had a macroadenoma. These microadenomas increase in size during pregnancy. So we should take the patient seriously. There might be a field defect and she might be thinking that, okay, it's a vision loss. Cortical blindness, the pupillary reaction is fine. Everything is fine, but the patient doesn't see. You get a imaging, the CT or the MRI, and you can get lesion in the striate cortex in the occipital lobe. And while here, let us not forget malingering. VP will help us in ruling out the malingering. There's another case of a 27-year-old primey, sister of an ophthalmologist, vision loss. She was having hypertension in pregnancy, vision loss after her discharge. The BP was 180/100. I thought cortical blindness because of the BP, but no. The imaging showed a posterior reversible encephalopathy syndrome where there is a vasogenic edema due to the hypertension, and then this resolves. She regained her vision after a week's time. So these are the way we can evaluate a patient who comes with clues in the optic nerve, or when we are suspecting some problem in the optic nerve, we order the field, we get an MRI, OCD, B scan, whole lot of tests, glucose, blood pressure, Doppler, vitamin B12 levels, lab tests, different lab tests. It has to be a very targeted ordering of tests. There's a whole lot of them. And just to conclude, always take, in case of whenever you're suspecting optic nerve lesions, so as to not miss a diagnosis, always take a full neurological and ophthalmic history. Ask specifically about any headaches, hypertension, or diabetes. Other tips are, don't dilate the patient's pupils unless you have seen that there is no RAPD. Pay attention to the perimeter of the disc. Look for the RNFL opacification with obscuration of the retinal vessels overlying the disc margin. Note the color of the disc and any abnormal vasculature. Look for a spontaneous venous pulsation. Look at the other eye. To assess the optic nerve function, check the visual acuity, color vision, contrast sensitivity. Do a visual field test. Look for a large blind spot. Assess the patient's neurological symptoms, system, and cranial nerves.